coordinator at Positive Living BC. I wanted to thank you all for joining us today. Today's presentation is a treatment update presentation, and it's called Is It Fat or Is It That? We've ordered a bag lunch for everyone. Some of you have already got them. So anyone who showed up or didn't RSVP or didn't make it onto my list, I apologize for that. There's still some extra ones left over, so you're welcome to grab one if you'd like. We'd like to acknowledge that we are gathered here on the unceded territories of the Coast Salish people, which includes the Musqueam, the Squamish, and the Tsleil-Waututh people. So we're grateful to be sharing this beautiful location with the stewards of this land. Before we get started, I'll ask everyone to turn off your cell phones or turn it on to vibrate, just as a courtesy to those around you. The presentation is being broadcast live on the internet as a webinar today, so there's a couple of people joining us online. Any pictures that are being taken are just going to be at the front, so it's not to be trained on the audience at any time. So we'll be recording this presentation for future broadcast on our website as well. I think it's best if we save questions for the end. Dr. Bonnie is going to give his presentation. He has a lot of data to go through, a lot of information to go through, and then we'll ask questions at the very end. You're welcome, because we're going to be online, you're welcome to say your first name if you wish. You do not have to disclose your identity at any point. We're pleased to have the support of Fair Technologies for this presentation today. They have generously supported us. They bought lunch for us. They made all the arrangements, and that was really terrific of them to do. So thank you to them. Distributed on all the chairs, everybody sees that we have a Positive Living magazine. In that magazine is an article about this topic today. So we talk a little bit about what the difference between the kinds of fat that some people living with HIV experience, and that's what Dr. Bonnie is going to talk about today. Also, there's a 2-page evaluation form, so it's double-sided pages. I always ask everyone, before you leave here today, please fill out that evaluation form. On the front is just some basic demographics that tells us a little bit about who you are and where you come from. And on the back, there's some spaces for comments. And that's really the information that I'm looking for to help us give more relevant information that's going to be more impactful for you. I'm going to introduce Dr. Bonnie. So Dr. Greg Bonnie is Clinical Associate Professor of Medicine and Pathology at the University of British Columbia. He's a member of the Division of Endocrinology at the Department of Medicine at St. Paul's Hospital. He is the Director of the IBC Metabolic Clinic and the Associate Director of the Healthy Heart Prevention Clinic at St. Paul's Hospital. Dr. Bonnie studied medicine at the University of Toronto, and he did his postdoctoral training at the University of Western Ontario. He was a member of the Department of Medicine at McGill University, the Royal Victoria Hospital, before moving to Vancouver. His research and his clinical interests include dyslipidemias, type 2 diabetes, metabolic abnormalities associated with HIV therapy, and metabolic disorders linked to psychiatric medications. So please welcome Dr. Bonnie.
Well, thank you, Brandon, for those kind words, and thank you for inviting me. I see a lot of familiar faces here, and it's nice to see all of you. It's too miserable a day today to be outside anyway. So what I'd like to do is go through, as Brandon alluded to, we're going to talk about abdominal fat, and I'm going to talk to you about visceral fat. Okay? Very simple objective. We're going to look at body fat redistribution with regards to the fat that's packed around your organs, and I'll tell you how we assess that. I will spend some time looking at treatments for this, lifestyle, and medications. I'll talk about GLP analogs. I'll spend a fair amount of time talking about growth hormone releasing factor analogs. That's a medication called Degrade. Okay. Oops, and that's my disclosures. So I don't need to tell people in this audience that people with HIV are living longer. It's actually a very interesting slide. There's like 75,000 plus individuals with with HIV in Canada. And if you look at that population, probably half of them are over the age of 50. You're not dying of HIV-related diseases, at least not to the same extent, but you're starting to experience the process of aging and the complications of aging itself. So that includes heart disease, diabetes. Those are the things that I treat. And again, that's just showing on this slide, the big crucial was in the mid-1990s when highly active antiviral therapies were introduced. And as you can see, the death rate from HIV-related conditions plummeted, but as people started to survive, other things started to develop. Lipid issues, vascular disease, diabetes, bone problems. Now, in terms of these comorbidities, as you can see, when you compare non-HIV people with HIV have a much higher incidence of vascular disease. They have higher incidence of kidney diseases, blood pressure, diabetes. As you can see, obesity is becoming an increasingly important problem. Why this is happening is still open to conjecture. Most of it probably is related to inflammation. Now, we've known for years that in people who have, say, rheumatoid arthritis or inflammatory bowel disease, they're at increased risk for getting heart disease. HIV is very similar. It's a chronic inflammatory condition, and that likely attributes to a lot of the different things we're seeing nowadays. Now, one of the main players in inflammation is your gut. Now, it's very interesting. I treat a lot of people with diabetes, and you'll find that there's a marker in your blood called CRP. CRP is a marker of inflammation in your body. Now, you can plot the level of CRP based on your gut size. As your gut moves out, your CRP goes up. As you lose weight, your CRP goes down. IL-6 is very similar. IL-6 is another biochemical marker. Many people like using that in people with HIV, but it's something that's not as easy to measure in the blood as CRP. So I use CRP more often. Okay? But again, the whole theme here is your gut, specifically fat packed around your organs, makes your inflammatory markers go up, and that's not a good thing from a vascular standpoint. So, what about abdominal fat and HIV? Again, there's some terminology you need to know about. Again, this is dating back early on when we started using antivirals. That's actually one of the first reasons Dr. Montana asked me to start coming to the clinic, is people were developing fat loss. They were losing fat in their arms and legs and face. And then in another group of individuals, they were getting big bellies. And as you can see, you would lose fat in your arms and legs and in your butt, and you would gain it in your belly. Now, metabolically, that's a really bad scenario, and I'll tell you more about that. And fortunately, the fat loss is virtually disappeared with the new antivirals. I still see the fat accumulation, but limb loss, facial wasting, certainly, I virtually never see that anymore. Now, I don't see cervical humps as much, but I still see them. Probably about 2 to 3, even up to 5% of individuals will get this. This gentleman, this is from Dr. Montana's collection, he had an enormous buffalo hump. He actually had that liposucked, and it grew back within 5 months. It was amazing, actually, okay? And fortunately, we don't see that much anymore. I still see it. I still see individuals getting fat accumulation in their neck. The belly fat is actually the most common form of fat accumulation that I see. Actually, despite what Brandon said, you can ask me questions as we go along. Okay. So again, fat, it depends where it's located in terms of its effect on your metabolism. Sub-Q fat generally is not as harmful. You might say, well, it's not very attractive. But basically, from a metabolic standpoint, it's the fat that's packed around your organs. That's the most important component. And that can be sometimes difficult to assess. And I'll tell you how we do that. Really, the only way we can scientifically assess intra-abdominal fat is to do a CT scan or an MRI of your belly. And as you can see, here's two individuals. The person on the left has virtually no sub-Q fat. You can see the abdominal wall it's very thin. But look at all this black area that's located here. That's fat that's packed around your organs. And again, people can use programs to measure that amount of fat and generate a number, the absolute quantity of fat packed around your organs. Now, this person on the right, you can see has virtually no fat around the organs, but has a lot of fat under the skin. So that's sub-Q fat. Believe it or not, that's not that important from a metabolic standpoint. Okay. Now you might ask, can my doctor order this? Well, in BC, really, there's not a real good mechanism. The problem is they'll do a CT of your abdomen, but they don't have the software to actually measure the amount of fat that's packed around your organs. So, these are two important numbers. Basically, 130 square centimeters. If you're greater than that, that means you have significant intra-abdominal fat, and that's been scientifically shown that once you have that amount of fat, it increases your chances of developing vascular disease and other metabolic issues like diabetes. Okay? And that amount of fat roughly correlates with a waist circumference of 95 in a man and 94 in a woman. Okay? It's not a perfect correlation. And again, if you get that number, you need to do a CT of your abdomen. So you might ask, well, there's a lot of new drugs out to treat HIV. The companies are all claiming that they're more metabolically friendly, they don't make your lipids go up, et cetera, et cetera. Well, it's very interesting. Even with the newer generation drugs, like the integrase inhibitors, they're still causing intra-abdominal fat. In fact, this data suggests that they cause it even more than some of the older drugs. They don't like to publicize that, but basically, that's what's happening. The reason it's difficult is we really don't know what causes this and why certain people get it and other people do not. HIV obviously plays a role, but your genetics also likely play a role. Certainly, you know, certain families, everybody tend to have a certain body habitus, whereas other families, everybody seems to be thin. So genetics play a role. Lifestyle is a very important component. You might have the genetic predisposition, but it won't show up until you do things that aren't really good, meaning you don't exercise, you eat too many calories. The aging process certainly plays a role. Certainly as you get older, you tend to get a gut. That's probably related to a number of different hormones. The antiviral therapy probably plays a role. And then chronic inflammation is also something that likely influences fat growth. Okay? So that's fine and dandy. That's basically what I'm telling you is we haven't got a clue what's causing this. Basically, the next part of the talk is how do you manage this from a pragmatic standpoint. So these are some of the skills that I use to monitor body fat. You can measure body fat directly. They used to sell these machines called electric impedance. Basically, it would look like a very fancy amplifier. You would hook the person up and pass electricity through them. And fat conducts electricity different than protein. And it'll generate a percentage. Can you think of why that's not a very good technique? Well, it doesn't tell you where the fat is. You can tell someone they got 30% fat, but you know, that fat might be all in their head. Basically, it's not going to help you, okay? Same thing with DEXA scans. DEXA scans is the same machine that does bone density. You can twiddle the knobs and use it to determine your body fat percentage. But again, the same problem. It tells you your overall body fat. It doesn't tell you about your gut fat. Really, the only meaningful measure is a CT or MRI of your abdomen. And then you use software to determine how much is packed around your organs. You can have someone who takes skin fold calipers and measures your skin fold. But again, that's measuring sub-Q fat. There's no way you can measure intra-abdominal fat. And you can do waist-hip ratio. And I told you, waist circumference. Of all these things, this is a rough approximation. Really, the only things I use nowadays is a waist circumference and a CT of the abdomen. So those are the two tools used to look at body fat. And again, how do you measure the belly is an important technique. If you ask most doctors, they say just put the tape on the belly button. And you think of why that's not a good idea? What happens to your belly button as you get older?
Drops.
It tends to move around. Okay, so in many guys, they say, "Oh, my waist is 32." Well, it might be down there, but up here it's not. Really, to measure your waist, you got to find the tops of your hip, and then it's the bottom of your rib cage, and then halfway is where you measure it. Okay? So to do it properly, what you do is you do those two bony marks, use a magic marker and mark it. And when the patient comes back 6 months later, you can measure it again. And if they haven't erased it, that tells you something also. Again, I told you CT of the abdomen and all that white stuff represents intra-abdominal fat. And again, people always remember the whole concept of apple shape versus pear shape. So again, an apple shape is gut fat. That one's metabolically not a good thing. Pear shape means you put all your fat in your butt and your thighs. Now again, metabolically that's not a bad thing to do. It doesn't make the sugars go up. It doesn't look very attractive, but basically if you're going to put fat on, pack it around your butt rather than your belly. Okay? You don't have a choice in the matter, but that's from a metabolic standpoint. Again, I always like using my old sumo wrestler guy because this guy's 26. He's eating 10,000 calories a day. He's really big, and most of his fat is sub-Q. If you measured his blood sugar is perfectly fine. Once sumo wrestlers retire, they keep eating and they don't exercise. All the fat goes to their gut. And literally 85% of them will get diabetes. Most of them will get heart attacks before the age of 50. And again, we've studied this. You know, I treat a lot of people without HIV who have metabolic syndrome. And this guy is meant to illustrate that as your gut goes out, you get all kinds of metabolic issues. Your lipids get worse, you get very high triglycerides. Triglycerides, which is a fat in your blood, it almost correlates with your belly size. As your belly goes up, your trigs go up as well. You tend to get high insulin, you get glucose intolerance, it sets you up for diabetes. And if you look at the blood vessels, as your gut increases in intra-abdominal fat, it sends out hormones that your blood vessels do not like. Your blood vessels become irritated, they don't react the way they should. It's probably one of the reasons why people with metabolic issues have increased risks for heart disease. And again, when you look at metabolic syndrome, which is very similar to HIV and intra-abdominal fat, it's about 40% of people over the age of 60. So it's a really big problem, and it keeps getting worse. Okay, this is actually pretty old statistics. It's probably closer to the fact 50%. If you're Mexican American or Black American, it's probably approaching 60 to 70%. And again, why do we worry about it? Well, it increases your risk for heart disease at least twofold. Some studies it's fourfold. Your risk for getting diabetes is increased tremendously as well. And again, the whole reason I bring that up is having intra-abdominal fat sets you up for heart disease and diabetes. And of course, we'd like to prevent that. So how do you treat it? Well, here's some of the things that I do. This is for both HIV and non-HIV individuals. Diet is important. Who's tried the ketogenic diet here? How do you like it?
It works.
Yeah, it does work. And how do you feel on it?
Actually, I felt okay, but what I'm finding in the long term, it's very hard to keep up. I mean, you do want to eat carbs.
You do. Carbs taste great. So ketogenic diets do work. The problem is durability. The other thing I'll share with you is some of the highest cholesterols I've ever seen are on people on ketogenic diets. Okay? Because they eat almost exclusively fat.
What is in a ketogenic diet?
Ketogenic diet basically means, well actually Lauren can tell you, but you can't eat any carbs and you get most of your calories from eating fat. See, when you eat fat, you generate a lot of energy. One of the byproducts of burning fat is a byproduct called ketones. Now, I don't know if you've ever noticed people when they've been fasting too long, they get a very fruity odor to their breath. It's like acetone. Acetone is a ketone. And that's what you get. We used to see that in people with diabetes, type 1s. Type 1s get ketoacidosis. That's the extreme form. They produce so many ketones that they actually become acidotic. And that's a serious medical problem. The ketogenic diet, basically the whole concept is you make your body start burning fat, you don't use carbs, your insulin levels go way down, and a lot of people do really well on it. But you got to be able to, generally have to fast for at least 12 hours. You certainly got to start loving bacon. Okay? Some people find that's not an issue. Other people, once they've done the diet, they say, I can't look at a piece of bacon again. So again, there's lots of diets out there. I'll be honest with you, the only diet that I recommend is a Mediterranean diet. Mediterranean diet's been around for obviously a long time. And basically it's plenty of vegetables, lots of fiber. You can have pasta as long as it's whole wheat pasta. Actually, what I like about the Mediterranean diet is you're allowed up to 8 drinks a week. In fact, that's the minimum. Olive oil is also a very desirable fat. There's a really interesting trial sponsored by the Spanish Virgin Olive Oil Association. And they actually took people and they allowed them to stay on a Mediterranean diet. And then half of them were given jugs of virgin olive oil, and they had to consume at least 6 tablespoons a day. That's very interesting. In that trial, when they looked at it after a period of time, consuming olive oil in that quantity reduced your chances of a heart attack or stroke by 28%. It's one of the few trials that have ever been done with food that actually shows that it can prevent heart disease. So Murray, do you think you could follow a diet like that?
I would gladly do
Okay.
that. That's kind of been the goal.
Okay. So, diet is always very important. The problem is, how do you get people to follow a consistent diet? Same thing with physical activity. Physical activity is a real big component, and I wish I had a pill that would make people exercise. Because I would take that pill myself. Okay? So, that's a real tough one, but physical activity is a really important component here. People always say, well, can't you just send me off and get surgery? Well, you can do that for humps, and I told you they grow back half the time. But for intra-abdominal fat, you really can't go in there and suck it out. Okay? You gotta do it. It's a metabolic problem. You gotta use a metabolic way of getting around it. When I mean metabolic way, I mean you gotta use pharmacological agent. Okay? So let's talk about that. Again, before I do that, when I see someone who's struggling with their weight, I always go through a list. Okay? So there are certain medications that can make you gain weight. Okay? Certainly medications used to treat depression. There's a medication called olanzapine. That's an atypical antipsychotic. As soon as you go on it, you almost gain 30 pounds. Okay? Now, it's great for removing your hallucinations, and you got to stay on. It's very effective that way. That's one of its consequences, is it makes you gain weight. It probably makes you feel better so that you eat, but it seems to also stimulate your brain, and you really lose appetite control. Okay? And people always say, well, isn't there a problem with my thyroid? Why? Maybe my thyroid's not active enough. I'll be honest with you. Thyroid problems causing weight gain are like 0.001%. Okay? You can't blame your hormones most of the time for this. Okay? And again, these are some of the medications I alluded to. The antipsychotics, lithium. SSRIs are drugs like Prozac, Celexa, Effexor. They're all mood drugs, and psychiatrists have a tough time with these. Because one, their focus is to get you back on track. They want you to feel better. The problem is you develop a lot of metabolic issues, and that's not really in their ballpark. So they often refer people to me to help with this. And as I'm going to show you, some of the medications they use to treat diabetes help with weight management. So why do I put the hoolies up? Because this is a bit of witchcraft I'm going to show you. Again, one of the key things is when you ask someone, do they want to lose weight? Everybody says, oh, of course you want to lose weight. We've got to be prepared to do something about it, okay? So that's really the action phase. If you really are not interested, we're going to wait till you are, okay? And again, I put this up because I can't tell you what's a good diet or a bad diet anymore. Okay? So certainly, if you lose weight, and that usually means you got to cut out simple carbs, those, as long as you lose weight, your metabolism is going to get better. The challenge is how do you do it? Again, like I alluded to, ketogenic diets are very popular right now. Actually, in that, what's good for you in there?
Bacon.
Eggs.
Eggs are good for you, actually. We used to always say that the milk's good. Skim milk is good.
Multi-grain toast.
Multi-grain toast.
I think it all is.
These are hash browns. Are hash browns good for you?
Without the oil, yeah. Are they homemade?
Actually, white potatoes are like eating glycemic index?
Yep.
Big glycemic index is as certain foods make your sugars go up. And it's very interesting how they do this. They actually hire people, generally in Toronto, and they go in a room and they give them food, and then they measure their sugars at baseline and then 30 to 60 minutes afterwards. So it's very interesting. Foods like potatoes, things like rice, they'll make your sugars skyrocket. Well, those have very high glycemic index. Is sweet potato good for you? Yeah. It's actually good. It actually has a moderate glycemic index. So if you have a hankering for fries, go for the sweet potato. Okay?
Brown rice is better.
Brown rice is better, actually. So generally, higher fiber is good for you. So brown rice, whole wheat pasta. Most people don't like whole wheat pasta, but if you like it, good. You're way ahead of the game. So what about anti-obesity drugs? None of these are currently available. We used to use a drug called sibutramine, which works centrally. It really wasn't very effective. There was a drug that blocked the cannabinoid receptor in your brain. Now, of course, if you smoke marijuana, you get the munchies, isn't that correct? And they exploited that fact. They developed a drug that actually blocked your cannabinoid receptor. And it's actually quite effective. But they pulled the drug from the market. Why do you think they did that? They actually became suicidal. Very interesting. So Sanofi was the maker of this drug. They bet their whole future on that drug. And they actually launched it in Europe. And then they found that there was a bump up in suicide rate. And they said, if you're going to use it as a weight loss drug, you got to be cleaner than that. So they had to pull it. Orlistat, which is Xenical. Has anybody ever taken that one? I don't use it anymore. It's a horrible drug. Basically, it's a pill you take, and what it does is it blocks fat absorption. Now, that's actually a good thing in general, but the problem is if you do eat fat, you get profound diarrhea and bloating. Okay? So it was a useful training device, because if you took the pill, and if you didn't change your ways, you'd have to change your pants because you ate fat. And you had no warning, by the way. That was it. Okay? Now, liraglutide is Victoza. And I'll just tell you about that one. Okay, when you eat food, your gut, your intestine, makes a hormone called GLP. It's actually the way your gut talks to your pancreas. So it makes this hormone, goes in the blood, it lasts about 1 to 2 minutes, and then it secretes or releases insulin and another hormone called glucagon. And people who have diabetes and people who gain weight don't make enough of that hormone. That's part of the problem. So you don't have adequate release of insulin, you don't have adequate suppression of glucagon. And the other thing we have found out, that this hormone talks to your brain and tells you you're full. Again, people who gain weight don't tend to get that signal. So about 15 years ago, they synthesized GLP, and they made it last longer. And there's 2 on the market right now. There's one called Victoza, and there's one called Trulicity. They're used for diabetes, but as a side effect, people lose a lot of weight on those.
What does it say in yellow? I can't read it.
I can't either, but okay. The one box is DPP4. That's an enzyme that normally breaks this down. So we actually have a pill that will prevent that enzyme from working. It allows your natural GLP to accumulate. And it doesn't make you lose weight. This one is GLP receptor agonist. Okay? And that's the drug Victoza or Trulicity. So it was all so successful that the makers of Victoza got the indication as a weight loss agent. It's now called Saxenda. So it's a GLP receptor agonist. It's an injection. The main side effect is it can cause nausea, but you'll have people who will lose weight. Now you'll get what are called hyper-responders. There's certain people who really lose a lot of weight, whereas 60% do not. So if you're lucky, you lose weight, and most of that weight you lose from your gut. And the other benefit is it's really safe, doesn't cause lows, and recently was shown it reduced vascular events. So not only is it safe, it actually helps prevent vascular events.
Anecdotally, since before I took my appetite was incredible. I could eat easily 3/4 of it just with chicken by myself, and it's in a guilt I would eat less, but I could. And since taking that, God, I can't go to the hospital.
So you're really illustrating how it works. And you know, the other benefit of it is it's really, in the diabetic world, it's as effective as using insulin. It's a lot safer because it can't cause a low. The only downside to it is it costs a boatload of money. It's about $5 to $7 a day. And the government of BC will never cover it. And again, this is the trial. I'll just quickly scroll through that. This is
it's cosmetic.
what's that?
Because you see it's cosmetic.
No, it's actually, this trial showed that using a drug like liraglutide actually was safe and prevented heart disease.
Okay.
So it's actually got that indication. But the government of BC just says, well, it's too expensive. You got other things to lower your blood sugar. Use those other things. Okay? I don't agree with that strategy, but that's what they've done.
Another question. If a person is on Victoza and they have noticed no weight gain or weight loss,
Yeah.
and nothing has changed, is it recommended just to stop taking?
Yeah. Unless you have diabetes. If you got diabetes, you should stay on it. Okay? It's a great drug for diabetes. But if it's not inducing weight loss, especially if you're paying out of pocket, I would just stop. Okay?
Would you extended medical coincide with BC government probably, or?
Extended, a lot of plans do cover it. But to be honest with you, they always ask me, is the person diabetic? Do they have a body mass index above 27? So there's a number of hoops that you have. So it's a challenge. A lot of my HIV patients that I use this in are not diabetic. So I always tell them that, can you come visit me in prison when they lock me up for fraud? Basically, I'm fibbing a bit here. I say the metabolic consequences of the abdominal obesity is such that I feel it justified to use. But technically, there's a lot of rules in medicine, and they say, okay, is that drug indicated for this?
Pre-diabetic.
It's not really indicated for that. Okay? Now I'm going to finish off with Agrifta. Okay? Now Agrifta is totally different. This is another hormone. This is what's called a growth hormone releasing factor. That's a fancy word, meaning there's hormones in your brain that are released that regulate the release of growth hormone. And again, growth hormone is an important hormone for a whole bunch of things. Every cell in your body needs growth hormone. Now, 50 years ago, it was noted that people who were growth hormone deficient, especially in men, they got guts. They got like a beer belly. And if you gave that person growth hormone as a replacement, the gut would disappear. Now the problem with regular growth hormone is it can, if you take it, it can make your blood sugars go up and it can give you joint issues. So Agrifta was developed. Agrifta is actually growth hormone releasing factor analog. The long and short of it is, it gives you all the benefits of growth hormone without the downsides. It doesn't make your blood sugar go up, you don't get the joint issues. Now, it's turning out to be an effective treatment for intra-abdominal fat. And it actually has the specific indication. If you have intra-abdominal fat greater than 130, you are eligible to go on this medication. And I'll show you, it's effective in a significant number of people to mobilize intra-abdominal fat. Okay? So again, to be eligible to go on EGRIFTA is you have to have a visceral fat level of greater than 130. And I told you how to do that. Now I'll tell you, it doesn't make you lose weight. It mainly mobilizes your gut fat. And they've done several trials to get this indication. There's 2 trials that basically showed when you went on EGRIFTA, 2 milligrams a day, basically it reduced your intra-abdominal fat by those amounts. It's roughly 18%. Okay?
Without weight loss.
Yeah, it's
So
just,
where's the fat go?
it mobilized inside the gut and disappeared.
Without weight loss.
Without weight loss.
Like burned off?
You lose fat cells. You can lose fat cells. They basically die. Okay? Now, it's interesting. It takes about 3 months for a fat cell to die. But that's how it does this, I can't tell you. Okay? But what they do is they take the baseline CT, and then at the end of the treatment period, they measure it again. And that's what they see. Now, the other thing is these figures are a bit misleading because a lot like Victoza, there are what we call hyper-responders. These are individuals who lose a boatload of intra-abdominal fat. It virtually disappears. And I got a couple of people on EGRIFTA that have shown that basically they've had a dramatic improvement in their belly fat. I've also had people who didn't budge an inch. They didn't lose any weight. Okay? So it's a bit of a crapshoot. And do you have to stay on it? Well, this trial is meant to show you that here's a couple of individuals. Here's an individual that stayed on the drug the whole time. Here's an individual who stopped at midway, and as you can see, they start to gain fat again. Here's an individual who was on placebo, and as soon as they went on the drug, they lost the fat. So the long and short of it is, if you respond, we keep you on it. And as long as you stay on it, your gut fat will remain, it'll be improved.
And it's strictly an injectable.
It's an injectable. Again, polypeptides, it's very interesting. Insulin is a protein hormone as well. And they've tried to develop nasal insulin, and they even went to the point where they actually launched it, but it's just not as effective as sub-Q injections. And there's a lot of other side issues with so basically, in most polypeptides, well, almost virtually all polypeptides, we have to use injections. Okay?
Just status that just so you can see what the side effects were. Thanks.
Okay, so side effects, again, I'll be honest with you, these aren't very common ones. The main one is they'll get site injections. That's actually common to most injectable therapy. Okay? So unlike growth hormone, you don't get your sugars going up, you don't get the joint problems that you see for
And growth hormone, you're talking about Omnitrope?
Yep.
Similar to that?
Yep.
So this would be
Same stuff that bodybuilders use.
same.
But this doesn't have the downsides, but you'll see the reason bodybuilders don't use EGRIFTA, it's about $3,000 a month.
Wow.
So that's the main downside. So it's very effective. It does improve your intra-abdominal fat. And I didn't have time to tell you that, but it improves your cholesterol, your triglycerides. If you have fatty liver, it makes it disappear. I suspect in the long run, it'll benefit the vascular system. That remains to be proven. And you need a really big trial to do that. It is $3,000 a month. There are a number of insurance companies that will cover it. And again, to go on it, you have to have a CT of your gut, and you got to have an intra-abdominal fat greater than 1/3.
How long has it been around?
It's actually been around for quite a long while, more than 10 years or so.
Just one question. So if they don't have the software to BC to work out what the scan says, what would you say?
Okay, so basically, the company that makes Agrifta realizes this. So what they do is they use a private imaging company that does the CT, and they send it off to a guy at Queens, and that person is an expert on intra-abdominal fat. They generate a number, and then that's how. But again, you have to be eligible for it, so obviously you have to have insurance.
In the previous shows, you had a decrease of 18%, something like that.
That's the whole
That's
group.
a 6-month period.
Yeah, but that's the whole group. If you select out the hyper responders, you're going to see a much more. You'll see some people that dropped it by 50%.
Does it expect to continue then through the years, or?
Well, that was the point of the one slide. If you stop it, your fat comes back. But as long as you stay on it, you're okay.
Dr. Bondi, I've been HIV positive for 20 years,
Yep.
and I sought out your support and advice over the years because of battling what we're talking about today. And, I've run the gamut of starting off like everybody did with the
Metformin.
First, even before that, it was diet and exercise. And it was going to the gym 5 days a week, doing cardio for an hour every day, trying to do that, maintain that, and pretty hard on a regular basis, seeing very few results.
Yep.
Then I went down the road of metformin, which didn't work for me as well. I was also somebody who tried Victoza and had little effect, and so went through injections in over a year. And then also went through human growth hormone, which was covered through my work insurance, which was great. Again, not having the best effect for myself. All the meanwhile, really hoping that, hey, something will come of this. I'll see some changes. I'm looking at those people, 30 to 40% who are these hyper respondents. Wow, I wish it was one of those. And so going through that, and at the end of it all, I actually ended up stopping my growth hormone. A year ago, they removed cancerous tumor the size of a baseball from my colon that they found through a colonoscopy. So, which is, one of those things that growth hormone contraindicated with.
If you have an active, that's actually.
Yeah, which I didn't know ahead of time, right? So I don't know which came first, chicken or the egg, but it's one of those things that we need to think about when looking at trying things in community. So I went, went through the operation, got it removed, quite difficult surgery, complications. Went back to my doctor, and and he suggested, well, Mark, you've tried everything else. Why don't we just try body contouring, like liposuction or something? I said, well, I've heard it doesn't work. And he said, well, let's give it a shot, even if it takes 3 years before it comes back, at least you'll have 3 years where you might have felt somewhat comfortable in your body again. But ergo, probably won't come up there, but along those lines, I've been on a waiting list for 2 years just to look at having a consultation for getting a surgery like that time regarding body contouring stuff. So I just wanted to share my experience. It's not everybody's experience, but it's my truth as an HIV positive person living with. Right?
thank you for that. It is a tough one. And the problem is we don't know what's causing it. If we knew what was causing it, obviously we'd be way ahead of it. It's very interesting. Insulin is a growth hormone like as well. So it tends to be anabolic. There's a lot of things that tend to make things grow. So it's always an issue that we have to keep track of. Basically, this is my second last slide. The gut fat causes the problems. The other approach is, well, we have drugs to lower your cholesterol, we have drugs to lower your blood pressure, we have drugs to make your blood sugar better. That's another approach. Manage those. But I can tell you, if you lose the weight, often the metabolic issues disappear. So this is my last slide. Body fat redistribution is a real issue. The main concern is it's not simply cosmetic. It does increase your chances of heart disease. You do get diabetes. I've gone over the treatments. I've gone over some of the medical treatments, GLP agonists, and growth hormone releasing factor analogs. I'll end my talk there and be very happy to answer any questions. Thank you.
I guess what I was struggling with would be, at what point do you and your doctor decide that you would be eligible or you should be going on something like a growth test? At what point, I mean, clearly, I definitely have seen development in the gut area, even though my diet is good, my exercise is good. But if it's that much of a risk to cardiovascular, when...
What's not a risk to your cardio?
That's not...
I give you that. Okay. The only the main contraindication to any growth factor is if you have an active cancer. Okay, because cancer cells grow. Okay, even insulin makes cancer cells grow. Okay, so it actually, if it lowers your gut fat, it should lower your vascular disease. That has. But again, answering your original question, who do you consider for EGRIFTA? Well, again, unfortunately, you have to have a way to pay for it. And two, if that's the case and it's eligible, actually a lot of insurance companies will cover it. The reason they will is there's not that many people in Canada eligible for it. And what they fear is large groups of people that need it. Okay? And like I said, to get the drug, you have to have a CT, and if your gut fat's over 130, you're eligible.
If you have an insurance company that pays for it, what happens when you start to top out your body with extended health plans?
That's the problem. That's the problem.
You're good to $100,000, and after that, not one turn.
It's
$36,000 a year. That's pretty easy to burn through.
It's a discussion I have. It's amazing. Biologicals, that's the emerging area in medicine. So we have biologicals, we have antibodies that we use to treat cholesterol problems now. Those are $7,000 a year. And the problem is, you're doing things for something that's going to happen 10 years down the road. So you can see you're going to burn a fair amount of money on something that you might not ever benefit until down the road. A lot of the cancer treatments are very expensive. It's very interesting, if you read the Globe and Mail about 2 weeks ago, they listed all the costs of medication in Canada. Now they excluded the cancer ones, but number one was biologicals used for rheumatoid arthritis. That's about $40,000 a year when you put someone on that. What do you think number two was?
HIV.
It was HIV and Hep C. Number three was drugs used for retinopathy, a complication of diabetes, which blew me away because in the top 20 there wasn't one diabetic medication. So they'll pay for the complication, but they won't pay for the drug that'll prevent it. Okay? So it's a real issue. Medicine's evolving where there's some really interesting drugs out there, but they cost a lot to develop. And unfortunately, that's the cost of doing business. There's a question over there.
I have, is this past situation, this has a prevalence in a specific ethnic group?
Okay. The big belly in certain ethnic groups?
Yes.
That's an interesting question. Now, small stature races like Asians, you actually have to lower your cutoffs because they're smaller people. The waist circumference is actually reduced. I showed you that 95. That's for Northern Europeans. For Asians, it's actually 10 centimeters lower. Okay? So, certain races you do have to adjust. Okay? The intra-abdominal fat, we still use the 130 cutoff.
As far as you know, are all anti-retroviral drugs equally guilty of creating this situation, or some that are
No one's really studied it. Hey, I really can't tell you. Okay? So that's still a real debatable one. Certainly the integrase inhibitors, they have beautiful lipids, they're very clean, very well tolerated. But there has been some data recently that shows that they do affect body weight and intra-abdominal fat. But again, it depends on how important that is. Go ahead.
Dr. Bonnie, you know me. My questions are more to do with, again, you're saying we have a higher risk of diabetes and a higher risk of heart disease.
Absolutely.
But I'm 68 next year.
Yeah.
I'm having more problems walking than I don't know anything about diabetes, and I don't want diabetes. Heart attack would probably get a gift but it would end my life, hopefully. I shouldn't say that, but my life is becoming more and more as I age with HIV, which I will be next year, 28 years.
Yep.
So I live through all that.
Yep.
My HIV is under control, but my body's falling apart.
It's actually with HIV you get a lot of bone issues. 85% of them have thinning bones or osteoporosis. So that's a real issue because you're getting fractures, you're getting other joint issues that are your age. You're about 10 years ahead of the curve. Okay? So you might be 68, but actually your body's saying you're about 70.
Okay.
I wish I could give you some answers on that. All I can say is with the newer treatments that we treat earlier, it seems to have benefits down the road. Right. You're suffering the consequences of having HIV diagnosed almost 30 years ago. Okay? So I wish I could reverse it, but I can't. And a lot of people, even that in non-HIV, their brains are fine, their heart is fine, but they need a new spine, they need a new skeleton.
My brain is fine, my heart.
That's the point of it.
I understand what you're saying, right? But I don't know. I don't think any new bones is just a lot. I think it's partly due to the S and my feet. I have neuropathy in my feet, and it's causing me not to be able to walk.
And that makes you gain weight. Sorry, over there.
Just as a curiosity, the pharmaceutical that's sponsoring this, do they happen to make Agripta?
They do.
They do, okay.
Yeah. So, I didn't mean to hide that or anything like that.
Pardon?
They don't have that many people on it, by the way. So, it's not been a big money winner for them.
Can a GP prescribe that, or would we have to
GP can do it. But, again, it depends. I think some individual physicians think they can do surgery as well. You got to know the hoops to be able to do it, okay? But there's no restriction on who can prescribe it.
Dr. Bonnie, I'll let you know the first time question.
If there's time, would you talk a little bit towards the sleep apnea feedback on this?
Well, again, sleep apnea is mainly it's not intra-abdominal fat per se, but it's mainly, that's a consequence of your body weight. As you gain weight, the tissues in your throat are affected, and many people develop sleep apnea as they gain weight. Conversely, when they lose weight, their sleep apnea disappears. That's not strictly speaking, okay? There's a lot of skinny people who have sleep apnea. But that's generally, and again, it's correlated. When you gain weight, you tend to get a lot of bad things happen to you. Sleep apnea is one of them. And again, sleep apnea is something you can treat. You can use CPAP. And if you lose weight, as I said, it often improves. But the key is actually making the diagnosis. I always remember, I scuba dive, and I remember you sleep in dormitories there. And I remember this one guy says, well, I hope you don't mind, but I snore. And then within 2 minutes, his head's on the pillow, and he's snoring. But what he would do is he would stop breathing. And I couldn't sleep because I said, is this guy going to live? The next morning, I told him, I said, I think you got sleep apnea. And he lived in Ottawa. He went back to Ottawa, and indeed, his doctor checked him out, put him on CPAP, and he says that was a game changer. His life, his energy is so much better. And I can tell you, a lot of people with sleep apnea die in their sleep because they become hypoxic.
So I'll take one question first, and I'll have those two questions, and then we're going to have to wrap it up. But quickly, I just wanted to ask about a drug like Atripla.
Yeah.
It's a very expensive treatment. Is there any, what's the accessibility? Is there anything like a trial or anything that I could get on?
There's really no trials ongoing right now.
Okay.
They did the initial trials to get the indication. Again, that's the limitation we have.
Do you know anything about the numbers of people who are using it right now?
In DC,
Yeah.
it's less than 10.
Yeah, the information that I have is that it's still a very small number.
It's a small number.
But in that regard, then, are there how many people would you estimate probably are eligible for this treatment?
Speak up.
I was just asking how many people might be eligible. There's currently about 10 people that are on this treatment.
Agrifta?
Yeah. But
I would say 10, but it's
yeah,
you know,
but a small
it's
number.
less than 10. It's a small number, and again, what I do is because of cost and coverage, I still go through the route of metformin if they can afford it, a GLP agonist. And then once they're there, then they do the intra-abdominal fat. In terms of percentage, that's an interesting question. I'd probably say it's on the order of 5% of the HIV population that have significant issues with intra-abdominal. You probably have a higher percentage if you actually measured it on everybody.
Sure.
But the people actually who it has a cosmetic effect, it's causing metabolic issues, that would be just a very rough figure. It would be over 5% there.
Yeah, I was just looking to get an idea. So Matthew, want to go next?
So what is the maker of Agrifta doing for HIV positive people to help either reduce the cost or make the government shell out for those who don't have private health care or who, you know, like he said, after a while, the amount you can spend gets topped up and then topped out and you can't use it anymore. What are they doing for us?
Well, they're a very small company, by the way. They're a Canadian company. So again, their resources on this is, I really can't tell you that, okay? I'm not connected with them whatsoever, okay? Now, all I can tell you from a political standpoint is there's certain other states who have lobbied and basically said, okay, if clinically indicated, and that would mean you'd have to have controls over this. You just can't go in there and say, okay, everybody in the world is going to be eligible. So you're going to have defined criteria. There are certain states that do it, but I can tell you in Canada, there's not a province that currently covers it. Okay? BC. BC is probably one of the worst in all of Canada. There's over 200 drugs that other provinces cover. BC does not. It's especially prevalent in the diabetes world. Okay? So it's an issue. And the other issue is, I'll be empathetic to, right now they're spending boatloads of money on fentanyl overdoses and drug addiction. Okay? So it's a tough one. So, but I would think in selected individuals you could lobby, because it's in this province all HIV drugs is bought centrally. You could argue there could be individuals that should be funded to the Center of Excellence for this as well.
All right, so I promised Melanie she could ask her question, and then I'm going to wrap it up for the day. And if anybody else has questions, they can just stay at the end, and we'll try and answer as many as we can before we have to go.
I hear a lot about lipodystrophy, but what about lipoatrophy? Because I have been trying to gain weight forever, and it's not working, so what can I do?
Well, lipoatrophy, as I alluded to, is not as big an issue. The drugs D4T and DDI were really the ones that cause it because when it comes to toxicity, you lost sub-Q fat that never comes back. Now, there are individuals with a genetic predisposition to losing body fat. Okay? There's actually a condition called congenital lipodystrophy. And these people have virtually no sub-Q fat. They actually lose butt fat and they get gut fat. They also get diabetes for it, which is very interesting. But again, even in these congenital ones, there's no known treatment for it. Okay? So it's a tough issue. And the only way we'll ever figure this out is we're going to have to figure out what makes fat cells grow or die. And it's turning out fat cells are a lot more complicated than we initially thought. There's dozens and dozens of hormones and growth factors that regulate the growth of fat cells. Okay? And until we figure that out, we probably...
So should I go on olanzapine so I can gain?
You'll gain weight, you'll gain most of it in your gut. You won't gain sub-Q fat. That's the problem. Now, interesting, insulin will make you gain sub-Q fat. But I'm not going to put you on insulin.
I need more bacon.
All right. Thank you very much, everyone.